I'm Vic Kashyap, and I'm proud to be co-moderating with Kenny Rosenfield here. And we're going to start out with Justin Dunn, who's going to talk about my challenges in starting a PAD CLI program.
Good morning, everyone. I'd like to thank the organizers for the invitation and opportunity to be here. So I'm going to talk a little bit about transitioning from fellowship into a job as an attending at an institution where there are multiple endovascular operators. This is something we don't talk about often at these conferences, and it may not be a one-size-fits-all talk, but I work in kind of an employment model, and we have multiple different endovascular operators, and I just thought I'd talk about some of the issues that I've come across. So when we talk about vascular disease, and you talk about multiple different endovascular specialists from different disciplines, there's a lot of talk about turf battles, siloed medicine, and the issue of ego does come up. And as we've seen in medicine across multiple disciplines, the idea of a multidisciplinary approach is kind of the hot topic. We talk about dyspnea clinics, multidisciplinary breast clinics, endocrinology clinics for diabetes patients, valve clinics. So, class 1 indication for patients with multivessel coronary disease, you take a heart team approach. You get a cardiothoracic surgeon, interventional cardiologist together, you get the patient's cardiologist in the room, you talk about the best approach for the patient to try to optimize their outcome. Same with valves. Aortic stenosis, TAVR has revolutionized the way we approach valve disease in these patients. And so you put together a valve team, you get together a cardiothoracic surgeon, you get together a cardiologist, and you try to optimize the patient. So what about vascular? How do you approach vascular disease in these patients? Who do you need on a vascular team for vascular disease of all types, not just critical limb ischemia, which is what we usually talk about with multidisciplinary approaches? So, like I mentioned, when you go to talks at conferences like this, everybody's talking about a multidisciplinary approach to CLI, which has been proven to be beneficial for patient outcomes. So you have the patient, you have their podiatrist that might refer the patient, you have wound care, you have nutritionists, endocrinology, and then you have some type of critical limb ischemia interventionalist of some discipline. So what about the other multidisciplinary disciplines within endovascular? So you talk about interventional cardiology, vascular surgery, interventional radiology. So multiple people doing endovascular interventions within the same health system. So if you have a health system that has multiple endovascular specialists, what are the potential problems for your health system, depending on the type of health system you come from? Overemphasis on procedures. We've seen potentially in this type of situation where you have multiple different operators in different disciplines that kind of answer to different departments. You might take a patient in and you might push forward with the procedure more quickly so that somebody else in the institution doesn't do the procedure if you decide not to do it. Patient could come to you asking for a procedure, and if you don't do it, somebody else will. Lower patient satisfaction. If you have kind of different silos and patients get filtered between different disciplines, they may get contradictory advice about what they need and what they don't need. Missed opportunities for cardiovascular risk stratification. We all know that peripheral vascular disease patients have poor cardiovascular outcomes, and how do we best risk stratify these patients? And how do we optimize their outcomes? So as the health system moves toward potentially a value-based reimbursement system, what are we going to see within health systems and what gets rewarded? So collaboration will be rewarded. Interdiscipline competition will not be rewarded in a value-based system. Value-based system is you're taking care of your patients in your community the best way you can, in the most efficient way you can, with the highest quality. And efficiency and quality will be rewarded, encouraging coordination of talents within your health system. So what are the challenges of having multiple endovascular specialists within the same health system? Overlapping skills. We talked about a heart team approach to coronary disease. This is very different than endovascular. You have an interventional cardiologist and a cardiothoracic surgeon. I'm an interventional cardiologist. I don't do bypass surgery. They do not do PCI. So there's no overlapping of skills. Same with valves. Most surgeons, there are surgeons that do TAVR, but most surgeons do open heart surgery for the valve, and then you have an interventional cardiologist that does the TAVR. In vascular disease, in endovascular treatments, a lot of times there's overlap of the procedures. Fear of downsizing within your institution. If you try to gather all the endovascular specialists together and coordinate care among them, potentially your health system could say, well, we have a lot of people doing similar procedures, we need to downsize this. So fear of losing some of your members. Misaligned incentives. You want to incentivize people to collaborate, not to compete against each other within your health system. The idea of autonomy. Everybody who does endovascular work probably feels they do it the best way, and they want to maintain that autonomy. And then the idea that my care is comprehensive. This is something you might encounter when you enter a health system and there's, say there's a vascular surgeon that says, look, I do endovascular work and I do surgery. Why do I need another endovascular specialist in my health system? So if you have these different disciplines within a health system, how do you get them all to collaborate and coordinate and get along with each other? What are some different ways to do it? So you want to find a place where everybody fits and kind of a structure where everybody reports to the same institute. Heart and Vascular Institute, I think a lot of institutions have already developed this. This is some kind of structure where every discipline, whether they're under the Department of Surgery, Department of Radiology, et cetera, can have some kind of indirect reporting system to a Heart and Vascular Institute. So you can help coordinate care. Place vascular specialists of all disciplines within the health system's leadership. Put them on executive committees. Help them understand this not only gets vascular as a priority in your health system, but it also helps the vascular specialists understand the importance of collaboration within the health system for the health of the health system. Close proximity, just close proximity within your campus. So working side by side with, if you're a cardiologist working with a surgeon that you see routinely on a day-to-day basis, not someone that's across the campus that you rarely see, gives you more of a we versus us-them mentality. So building trust is critical. If you want to have collaboration among your endovascular specialists, you need to be able to build trust. How do you do that? You align incentives. So the incentives, if you have them misaligned, if you incentivize primarily fee-for-service, you're going to want people are going to want to take patients from each other. Shared accountability. Look at your endovascular work and your vascular care as an overall product for your health system, and have the accountability shared across all endovascular specialties. Regular vascular conferences, and use these vascular conferences as education. Everybody comes together, talks about approaches to different things. You see at conferences like this that an approach to an occluded SFA can be very different in very different approaches, different wires, different techniques, antegrade, retrograde, reentry techniques, et cetera. So learning from each other and having conferences where we can discuss different approaches, everybody tends to get better together, and it's better for the health system. These vascular conferences are not meant to be punitive. You do not take these as an opportunity to look at other disciplines' complications and exploit them and use them to show the health system that you should be doing it rather than somebody else. Set a high bar for quality. Use metrics that matter. The metrics that we are sometimes held to, things like statin use, tobacco cessation, et cetera, are excellent. We need to promote that for our patients, but set a high bar for endovascular quality. Set a bar for saying, look, if we have an occluded SFA, how often do we want to be able to get across that? What's our goal? And establish that across all endovascular disciplines. Identify individual strengths within your health system. If one endovascular specialist is really good at below-knee work and another one is really good at carotid work, be able to identify who's good at it and try to streamline patients to those individuals. And then embrace new members. If you have an endovascular program at your institution and somebody new joins that does endovascular, do not see them as competition, and again, depending on how your health system is structured, but see them as somebody that can augment your vascular practice and help your patient population in your community. So placing the patient in the community first and putting your health system first, I think, is the best approach to optimize your vascular program at your institution. So this is something that you may have at your institution, you may or may not have. I think it's difficult to establish a vascular clinic. It's something I'm trying to do at my institution. It's a single point of entry for your entire health system. So a primary care doctor or a podiatrist in the community sees a vascular problem of any kind, venous disease, lymphedema, PAD, carotid disease. They want to know where to send this patient. Do they send it to this doctor, this surgeon, this cardiologist? If you have a community and a health system that treats your community, find a single point of entry where they say, I'm just going to call the SUMA endovascular clinic or the vascular clinic, and then we will streamline the care from there. We coordinate the medical, endovascular, and surgical specialists and try to optimize care for the patient. We streamline testing, we streamline treatment options, and hopefully, in the end, we optimize the outcome for the patient and for the community. Thank you.
That was actually great, Justin. Really solid thoughts. So now it's my privilege to introduce Vikram Kashyap, who's the Chief of Vascular Surgery at Case Western.
Thanks, Kenny. Okay, it's amazing how similar my talk probably will be to Justin's. But I have a little bit more of a provocative title. I'm not sure if Kenny or Mehdi was responsible for this. A multidisciplinary team, why a surgeon is a must, ? And my title has changed. It's exclamation point ×2. Does everybody know what this is? This is my attempt at humor on Saturday morning. It's a no-brainer, folks. You have to have a surgeon involved. And even though Dr. Rosenfield, Dr. Shishabor, Dr. Dunn are outstanding interventionalists, every one of us, and I'm an endovascular enthusiast, quite frankly, we occasionally have a complication like this. And I urge you, if you're an endovascular specialist, to go to the operating room if you have a patient like this to see what happens when there's a significant hematoma or a complication. It's really amazing how blood can be very destructive in the subcutaneous space. It's like a bomb, went off, and you'll need a surgeon for that in most cases. And then the other thing, and you're going to hear more about this from Dr. Rosenfield, is the whole question of endovascular versus open bypass for patients with critical limb ischemia or PAD in general. And sometimes a bypass is the right option, and this is just an angiogram of a patient with a long segment vein bypass that goes down to the posterior tibial artery, beautiful pulse in the foot. And not only did this work for the patient initially, meaning that the patient healed the foot, but in some cases, I have patients that have had a durable bypass for 10 years or more, which is something that I think rivals any endovascular durability. So, to answer that one provocative question, of course, a surgeon is a must. But I think the more important question, really, and really what I'm sure Mehdi and Kenny and the organizers were getting to, is collaboration versus competition. And I think you'll hear that my thoughts are very similar to Dr. Dunn's slides. So interaction between multiple specialties is inherent to not only our practice, but really medicine in general, in taking care of patients with complex vascular disease. In fact, if we do this, and if we do it right, it improves patient care. The critical question is whether collaboration or competition is better for the patient and the institution at your particular locality, and I clearly believe that collaboration is better. So what are the different options when you have multiple specialties treating a similar disease process? And this, again, can be true for vascular disease, it can be true for venous disease, it can be true for cerebrovascular disease, it can be true for some non-vascular entity. You can have autonomy, that means you can have groups of physicians that are separate and autonomous, and this often leads to competition. You can have true integration, and there are very few places in America where this has happened. It's a challenge mostly from a fiscal standpoint, but if you truly believe in the vascular center concept, hopefully at some point down the road we'll get to this, where all folks that deal with vascular disease are tied together not only from a clinical standpoint, from a patient treatment standpoint, but also from a fiscal standpoint. As many of you know, those challenges are mostly fiscal. In terms of how to incentivize and appropriately reimburse different individuals. And then collaboration, which is probably the best model currently. So what's happened at University Hospital's Cleveland Medical Center in Cleveland? This is on the campus of Case Western, which is behind us. So if you look at 20 years, 1997, peripheral arterial disease endovascular treatment was mostly in the realm of interventional radiology. Vascular surgeons did very little of this. It was something that was just starting really for them at that point. I was in that case at that point. And interventional cardiology did mostly coronary interventions. And you fast forward to 2016, and it's a very different Venn diagram. And these circles also mean something. In not only was the change in the Venn diagram and treatment for peripheral arterial disease from an endovascular standpoint, but also the circles got a lot bigger over those 20 years. What's the current status for vascular disease treatment by different disease states? Well, if you look at cerebrovascular disease, you have neurointervention, vascular surgery, interventional cardiology, neurology, and aortic disease, you have vascular surgery, cardiac surgery, interventional cardiology, interventional radiology, and venous disease. You have even a bigger group of people, including general surgery and phlebologists and dermatologists. In AV access, also a pretty significant Venn diagram with radiology, surgery, and interventional nephrology. And when we get to peripheral arterial disease, at least in our region, it's mostly vascular surgery, interventional cardiology, and interventional radiology. Why is there a fear of collaboration? And I think Dr. Dunn pointed to this, why do we compete? Well, I think it's because of the fear of a couple things. I'm going to lose control of my patients. I'm going to train my competition. I'm going to lose clinical volume. I will not have access to innovation. Patients will go to other providers. And I'll just suggest our experience has not been that. At the Harrington Heart and Vascular Institute, we concentrate on clinical, educational, and research priorities, and if we work together, we can work on programs to improve patient care. We can decrease variability, which is pretty staggering sometimes across the enterprise. We have access to resources, clinical, educational research. We can increase volume and obtain fiscal data. And let me just give you a couple of examples of this in the last couple of minutes. In terms of having access to resources, clinical, educational, and research, well, one thing that we've done fairly successfully is marketed as a group to take care of patients, whether it be with venous disease or with dialysis problems or limb preservation programs or a diabetic foot clinic. We've done that together. We've worked together in terms of clinical trials, and over the last 7 years have started over 25 clinical trials and have had increasing numbers of patients enrolled in those trials working together. And these include some of the trials that you'll hear about, BEST CLI, but also in carotid disease, aortic disease, peripheral arterial disease clearly, and AV access and other vascular conditions. It's increased our volume. I think without a collaborative approach, we would not have seen this, but over 7 years, this is all vascular cases that are done either in the operating room or in a cath lab or an endovascular suite. We've gone from about 1,700 cases in 2011 to over 4,000 cases in 2017, and we continue to grow. We just had one stagnant year when we had some folks retire. And I think that is proof that this collaboration does work. And lastly, if you just look at vascular surgery, having partners that are very attuned to risk factor modification working with us, we now have increasing case mix index, sicker patients, which is in blue, but a mortality rate down to 1%, which rivals some of the best programs in America. So, ladies and gentlemen, in conclusion, I think collaboration between surgeons, cardiologists, other folks that deal with peripheral arterial disease in a heart and vascular institute model is clearly feasible. An institute model can provide more resources for practice, research, and education. Collaboration leads to increased clinical volume by growing the pie rather than fighting over the pie, and I think we're an example of that. So in this debate, collaboration clearly beats competition, and I'm happy to answer questions at the panel session. Thank you.
That's great, Vic. It's an example of the rising tide brings up all the ships, and I really think that's true. You know, one thing that neither of you guys said, which I think is really true, is that it's much more fun to practice in a collaborative environment than to be wasting our energy fighting over each other. So I'm going to talk a little bit about the scientific aspects of a collaborative trial. I'm the co-PI of the BEST CLI trial with my colleagues Alec Farber and Matt Menard, who are surgeons from Boston. So what will we learn was my topic. Where's the, I guess this is it here. So these are my conflicts. I just want to thank my colleagues and BEST and the NERI group who have really made this trial happen. It's an NIH trial. We all know that CLI has huge impact. We've heard about it for the past 3 days. Enormous burden and cost for society. And as you said, Vic, there's a tremendous variation, and even within institutions, about how people are treated, and a lot of controversy about how to treat, and there's obviously the cost. So we have a huge knowledge gap regarding outcomes and what's really the optimal approach for these patients. So if you have this patient who has a mostly infrapopliteal disease, but all three tibials are occluded and kind of looking lousy. I mean, they could be opened up percutaneously, maybe, or one of them. There's a good target downstream. Should you bypass this person, or should you take them to the endo suite? There are those two options, and on the right side, the endo options keep increasing in terms of the number of devices and technology and innovation and so on. And so that's sort of driven everybody towards endo, but we really haven't answered the question as to what patient is best for which treatment. And talking about variation, this is from VQI, which shows that in some centers in this country, if you show up with a threatened limb, you will 100% of the time get a bypass. In other centers, 100% of the time you'll get endovascular approach first, and then everything in the middle. And this should never be this much variation. There's just not that much, it's clear that in some cases, a person who comes into a place who'll get bypassed first probably would do better with endo, and vice versa. And there shouldn't be this much variation in practice across the country and across the world. And in fact, the reason for that variation is there's positive, high-level quality, high-quality data that's available to guide our decision-making. It was outlined very nicely in this paper by Skylar Jones, where they looked at all the trials in critical limb ischemia and found that there's really very little evidence base out there to drive our decisions. Most of the data are retrospective or poorly controlled with poor endpoints. There may be industry-sponsored trials and so on and so forth with moderate follow-up or incomplete follow-up, and it becomes just a mess out there to figure it all out. And in fact, if you look at clinicaltrials.gov, this is from a couple of years ago, but if you look through all these trials, none of them having to do with PAD are really level 1 evidence generating trials. They're just not robust. They're mostly industry-sponsored, trying to get advice approved. So the best CLI goal is to provide level 1 evidence to answer the question, what's the optimal treatment strategy for a given patient with CLI? Is it open or endo? And also to shed light on other aspects of CLI, like cost, quality of life, wound healing, all these incredibly important things that a lot of the other trials sort of pass over. This is likely to be the most important trial of the decade, and maybe beyond, for patients with CLI. It's not going to be repeated. It's incredibly important for us to get full enrollment and to follow up these patients closely, because I don't think it will be repeated. It's an expensive trial. It's over $25 million, funded by NIH. It's been a work of love for those of us involved, and including our investigators, Vic being one, and many others, Tino being one. So the objective is to compare the treatment efficacy, functional outcomes, and costs in patients with CLI undergoing best open surgical or best endovascular revascularization. It's a prospective randomized trial. It's pragmatic. That means we allow you to do anything that's approved, basically, to treat them, whatever you would do to treat the patient. And it's 2,100 patients at 160 clinical sites in North America, now beyond, each patient with 2-year follow-up. This is our North American sites. We have about 130 active sites, and these are our OUS sites. Some of them are just online recently. This is a 2-cohort design with looking at patients with a very good single-segment saphenous vein graft. That means that they have a good conduit for bypass versus, and then a separate quarter of the patients are being randomized between endovascular therapy and poor conduit bypass. So the patients who need a arm vein or short saphenous or composite or prosthetic or something like that. So the endpoint is also novel compared to other CLI trials. It's a major adverse limb event-free survival. That's freedom from death and freedom from above ankle amputation of the index limb, or a major intervention like a big bypass, or the need for thrombolysis in a graft, or need for thrombolysis in an angioplasty restenosis or something. So the idea is that we're not including the smaller reinterventions, like if you approach somebody with an endo approach, it's not unusual to say, well, I'm going to do this staged, or they probably are going to need a touch-up at some point in time. That's not considered a major reintervention, so that's not a primary endpoint of the trial. But it's a minor reintervention, and we are capturing that, as well as all these other key secondary endpoints: reintervention, postoperative death within 30 days, and amputation-free survival, which is the traditional endpoint for these types of trials. But this is, we believe our male-free survival is a much better primary endpoint, because it's really much more practical as to what matters from patient standpoint. Other secondary endpoints are freedom from clinical failure, freedom from recurrent critical ischemia or ongoing CLI, and freedom from hemodynamic failure. So we're capturing all these things within the context of the trial, as well as quality of life and functional status of the patient. So we take lots of testing. The coordinators get beat up, I guess, by having to do a lot of surveys and so on their patients. But at the end of the day, it's going to be a very rich source of data that will really inform us in the future about what to do with these patients. We also are looking at costs, which you guys have both mentioned are really important. And I do believe that working together, we can reduce costs, and we need to do. We have a responsibility to do that. We have a responsibility to understand what they are. And I don't think anybody in the world really understands what the costs are associated with CLI. So this will help us get at this. It's not going to answer the full question, but it will help us get at, this trial will help us get at that information. So the patients who enrolled are patients with CLI who are candidates for both open and endo in the eyes of the individual investigator. So this is a pragmatic trial. It says, if you, as an investigator, don't believe there's, well, equipoise, that you don't believe that they're candidates for both, then you do what you think is the best thing for the patient. But the reality is we don't have any data to base that decision on. So we're trying to encourage our investigators to think out of the box and stop, think about eliminating your own bias, because many of us are biased. I myself biased towards endo. I've become less biased towards endo actually as the trial's gone on. So you know, we have to acknowledge that everything we do is often based on bias and not necessarily on evidence base, and we are trying to create the evidence base, and without the sort of suspending your own biases, we won't get to the answer. And to that end, for example, we started out with some pretty important exclusion criteria. We then eliminated them all and said, look, unless you're really excessive risk for surgical bypass, you should be a candidate in this trial. And unless you've had something done within the past 3 months, endovascular, then you should be a candidate for this trial. Everything else is suspended. We say it doesn't matter. All these patients need revascularization, so let's put them all in the trial. And that's the way it's gone. And it's been I think we've increased enrollment as a result of that. So this trial, to the point of this session, can we all work together? This trial is about collaboration. It's inclusive of everyone who treats CLI, vascular surgeons, radiologists, cardiologists, vascular medicine specialists. If it's going to define practice, it needs to have everybody involved. And in fact, this is the investigators by specialty. Just by practice patterns, 75% of our investigators are vascular surgeons, and it turns out that, you know, most CLI patients in most hospitals around this country are referred to the vascular surgeons first, which is fine, as long as there's interaction and dialogue and so on. And I think Vic acknowledges that, for example, the vascular surgeons, the reason that Venn diagram is so big now is because you guys learned a lot of techniques from cardiologists, and we learned it from radiologists, and that's how I learned. So we all need to work together and talk together to get the best outcomes for our patients. So this is a secondary goal of the trial. And NIH will come right out and say, this is a secondary goal of the trial. We want to improve interdisciplinary discussion, teamwork, sharing of skill sets, collaboration, because we know that everybody will win and it will raise the bar of CLI care. So is this your hospital? Clearly not you guys now. How can we all get along? Well, actually, I was thinking about this. Here we are in Denver, and you know, it's one of the first states that sort of legalized this stuff. And I figured, well, this is one way to get along. We should all go to one of these bars first, and then we come. And before our CLI meetings, you know, that might work. I don't know. So we have really worked hard to define what's called the CLI team, which is one of sort of getting together. You guys have defined it. I won't repeat it, but it's having a venue, a formal venue, and then on top of that, informal opportunities to get together and talk about cases and talk about what's best for this patient, what do you think, da-da-da, and actually scrub together and have fun. It makes it much more fun. Obviously, aligning the incentives makes a lot of difference in that regard. If we can all get to that, that would be great. If it's value-based care at the end of the day, fine, but right now, unfortunately, a lot of the silos exist because of the payment structures and malalignment of incentives. In any event, requirements for this, as you guys have described before, requires mutual respect, collegiality, commitment to the concept and the process of a team-based approach, a willingness to sacrifice. That is a critical ingredient. You need to be able to sacrifice and compromise and say, okay, it may not go my way. That's okay, because at the end of the day, collaboratively, we'll all come together and we'll all rise the tide, like I said. Focus on the patient first. You said this nicely, Justin. Recognition that the team benefits the patients. And a self-awareness that you can't be all-knowing. I mean, I can't tell you how many times have you guys sat down around a table and there's somebody around the table that says, well, they know the answer, period. I've probably been that guy many times. Right, Tony? I probably have. But I try to, reduce that a little bit, lower that level, be self-aware that, other people have things to contribute. And acceptance that we can all learn from our colleagues. And you mentioned that very nicely, Vic. So here's the enrollment update. We're up to 1,416 patients, which is more than 2/3 of the trial. We have another year plus to enroll. We're really ramping up our efforts with our investigators to try to get them to just set aside those biases and enroll the patients. We have, interestingly, I thought that Cohort 2 would enroll more briskly, which is that the disadvantaged conduit, it turns out that Cohort 1 is enrolling more briskly, and that might be because of the fact that people don't have as much equipoise. A lot of surgeons don't want to operate on patients who are, really high risk and have lousy conduit. Anyway, it was a surprise. What will be best CLI add? I'll just finish up next couple of slides. It'll assess the role of endovascular and open when you have a single segment greater saphenous vein, a good conduit. It'll assess the role when you have a bad conduit. And it will assess the role as it relates to multiple clinical factors like the presence of tibial disease, race, gender, and so on and so forth. And this is covered up, but basically talking about the least cost and best quality of life, we want to achieve least cost, best quality of life for our patients. We're going to get a ton of information about CLI and real-world outcomes after different treatment options. We're going to learn about the fact that revascularization strategies, which ones are preferred by investigators versus others that are less preferred in the real world. We'll learn about the effect of quality of life, the effect of revascularization and treatment of CLI on quality of life, and hopefully get some feel about the true cost of CLI care. The impact of this, it will be the largest and most rigorous trial to date examining treatment paradigms for CLI. And hopefully this will help define and clarify what our approach should be. There are these non-enrolled patients, which are actually the majority of patients, and we hope to get at them with a registry. We're still working on that. But clearly, further study, even after this trial, will still be needed to inform us about this. This is really going to raise a lot of questions, this trial. It's going to be a rich data source, but it'll formulate the next question that we have to answer. So just in closing, I'll quote David Goff, who's the director of the Division of Cardiovascular Sciences at NIH. I thank you all for, this is from our recent investigators meeting, which was out of the park. I thank you all for what you're doing for your patients, for our country, and really the world to advance this field of research. What you're doing is so important, and I will echo that. The people on the panel, other than myself, Matt, and Alec, which are next to David, are Nitish Chowdhury is also the cost-effective guy. But then they're all NIH, CMS, and FDA leaders who really believe that this is a critically important trial. So thank you very much.
Okay, next we have Tino Pena, and he's going to talk about, I should have sent this one for bypass, case-based CLI.
It's really hard to follow Kenny and all this enthusiasm with a talk about what should I have done differently. But I think this is really important. And again, there's not that much data out there. I think really you start getting anecdotes and you start understanding, you know what, this is something that bit me a couple times. You don't want it to bite you again. And then what I'm going to show you are really cases, they're pretty recent cases. So obviously we need to kind of continue to look at these and try to guide ourselves a little bit better. And disclosure, I work at the Institute. We're in a group, in a multi-specialty group. So we have 6 vascular surgeons and 8 interventional radiologists. And we cover 5 hospitals with 3 different labs. And basically, we're all in the same group. So basically, we're all partners. So a little bit about things you've already heard, patients and bypass. And I think it's important to understand that there are lesion factors and there's patient factors. And trying to really kind of understand both of those as we make our decision. And then there are factors of, how comfortable are you in terms of doing your treatments, whether they're bypasses or endovascular procedures. I think patient factors, ambulation status is really important, comorbidities, that 2-year survival that we got out of the basal trial, we still aren't able to lose that until we have better data. And again, limb salvage rates are good, greater than 85% of those 2 trials, PREVENT-3 and the basal trial. So these are kind of some of the cases I'm going to show you, looking at when you should definitely consider bypass. I think it's important to consider bypass all the time. One thing that Best CLI has taught us is that you really don't, you think you know your partners really well, but you don't. And I think it's really important that every patient that we have basically gets screened by both specialties. And it really has changed the way we collaborate and work. Cases that I think you should consider bypass, obviously common femoral lesions, and we've already heard some debate in terms of really is a common femoral artery off limits or not. I think that we still need more data. And I think most of the time you think you can do a good job, but the question is, are you doing a durable job? And I think that's something we need to look at. Protecting the profunda at all costs. And that's really important. If patients lose their profunda, I think they're going down the wrong road. Severely calcified SFA. Yeah, you might be able to get it open, but what's your long-term patency? What are you really doing in terms of durability? Patients with small arteries, a lot of times they're small and maybe it's just a magnification. You know they're small. Watch out. Long segment disease. And again, what to do with distal runoff vessels. Try to protect that distal runoff vessel and try not to compromise them, particularly if the patient is a candidate for bypass. And that's why that discussion beforehand is so critical, because you can't make that decision when you're there, treating that patient. You need to know that ahead of time. So I'm going to show you a couple cases. This is an interesting patient, 52-year-old female, non-diabetic, non-smoker, comes in with severe claudication. It's just impressive to me the amount of atherosclerotic, calcific atherosclerotic disease that this patient had. Basically involved the entire SFA, the profundas, the popliteals, with occlusions, all the way, pretty much down. This is the patient where, picked up the phone and I called, I spoke to the vascular surgeon and I said, look, I don't think we want to do anything in this lady unless we really need to. And then if I need to, then I'm going, I think this is going to be something surgical for sure. And then let's start doing the things that we know we need to do. Let's assess her heart, her cardiovascular risk factors, and what have you. Second case, 61-year-old female, 8-week history of pain in the left foot. A lot of times these are probably one of the most difficult cases. You start getting this subacute time frame. You're really trying to find out what's going on. And you can see here that this patient has occlusion of that distal SFA on the left. You can see the non-invasives all really matching. Perform an angiogram, really see what's going on to treat and see if we're going to, what's going on here. Is this something acute? Is this something that we need to treat? And right off the bat, you can see the size of these vessels in this woman, very small vessels. Is it related because of that proximal occlusion? Well, look at the aorta. The aorta, the iliacs are small. And again, you see a focal abnormality in this distal SFA, a little irregular, good distal runoff. End up crossing it. Let's say, let's lyse it overnight. Just see what's going on. Maybe we can uncover something. And you can see here, a small unifuse catheter, went ahead and lysed the patient overnight. Didn't make it to that night. After about 5 hours, severe pain, had to come back in and really assess her overnight just because of, basically you're getting into a threatened extremity. And you can see when we got in there what we found. Basically, that whole popliteal artery pretty much occluded. I can tell you that catheter wasn't occlusive when I finished, but it became occlusive. You can see the distal runoff is there, but really required some work that night just to try to get some flow, and we had some distal embolization of some sort. So we started the patient on lysis again. The next day, we look, you see it lysed pretty well, and said, okay, what do we do now? I think the right thing to do probably would have been to stop. Went ahead and tried to try to get a more durable result, 3 millimeter, 4 millimeter angioplasty, and then placed this over for a 4 millimeter vessel, and looked pretty good, looked great. You're like, okay, we escaped. She's doing much better. I can tell you within 3 hours, that extremity was white. And again, acute changes to that limb. You can see what the non-invasive showed, operating room. Basically, you can see all that thrombus, all that clot that came out, plaque. Again, there must be something hematologic going on. Nothing. Everything came back negative. To me, this really has to do with the patient, small vessels. And if you can see on this exam, she also had issues on that right leg that she didn't have before we started. And I can tell you I was very fearful of doing anything on her. She came back 6 months later, and we were able to treat because she was really having critical symptoms on that right lower extremity. Again, to me, I think this is small vessels. This is that patient that you know you're not going to have a great result. Maybe this is someone who can get a bypass. Here's another patient, Rutherford class 6, ulcers first, second, and third toe. Look at the extent of occlusion here. There's probably chronic and acute problems going on here. all the way basically down from the external iliac down to the feet on the non-invasive. The CTA doesn't help us any. Day one, once you start seeing day one, you know it's going to be a long process here. Coming up and over, getting through that external, trying to create some flow down that limb, because you need to create something. These patients have so much disease. Again, placed a stent. Got the profunda was open, but no SFA. Decided and you can barely see a PT coming down. Decided, okay, let's go ahead, or the AT coming down in the DP location doesn't project very well. Said, okay, let's start some lysis after that. Next day, you see the external opens up well. Went after the SFA, got pretty much down into that AT, lysed that overnight. On day 3, again, you're really going and doing a lot of work. And this is, I think, this is where you need not to be stubborn. You'd be like, okay, when do I need to stop? Maybe this is not the right thing for this particular patient who's 59 years old. And again, going in here, you see stents in the SFA, lysis, we got flow, right? We did angioplasty, suction thrombectomy, everything we needed to do to create that single vessel runoff. Patient ended up getting their transmet, which we knew they were going to get. On the way out the door, we said, let's make sure this is going okay. You can see that run, you can see single vessel runoff, you can see what was going into the foot, you can see what the non-invasive looked like. 4.5 months later, they come back. That stent is occluded in the SFA. 11 days later, everything else is down, patient with a below-knee amputation. So again, could this have been avoided with a bypass earlier? When you look at that extent of disease, I think it's important. Finish off with this case, 51-year-old, again, leg pain, you can see the extensive disease. And what I want to show here is that profunda. Have respect for that profunda. When you see that profunda is gone, get in there. This is one of those things where I say, let's do either a combined approach or let's get a bypass and see if we can get a better flow. You can see here, again, it was a focal area, common femoral profunda, origin of the SFA, that kind of triad, that bifurcation. This is what we found, kind of probably some element of acute disease on chronic disease, able to get into that profunda, suction out of what we could find acutely, able to perform a small angioplasty, trying to get some flow in that profunda, then into the SFA. You can see how tenuous that bifurcation is. And I think here is, you don't want to lose your profunda, and this is what happened in this case. Lost that profunda, then having to do kind of really Hail Mary stuff here, right? Trying to angioplasty. You don't know how durable that's going to be. You don't know if that's the right thing for this patient long term. Yeah, we got it open, but who knows how long that's going to go. So in conclusion, I think it's important to evaluate, know your team, be very collaborative, have those discussions before you're going to jump in any of these cases. I think it's important to understand the patient and the lesion and kind of understand those limitations. I think there's a lot of factors involved there, and you have to know those alternatives. I look forward to what I'm going to find out of the best CLI trial. I think it's going to give us a lot of data and hopefully help us in this type of environment. Thank you very much.
Okay, folks, next is Bala Ramanan, who's going to talk about innovative approaches to build a CLI program.
Good morning. I thank the organizers for the privilege of the podium. I have no disclosures. So I want to start this talk with a case which highlights the importance of multidisciplinary team approach to these complex CLI patients. So this is a 57-year-old female who had a 1-year history of a wound on her foot, and she had undergone several vascular and wound procedures at an outside hospital, including atherectomies of her popliteal artery and the anterior tibial arteries and a popliteal stent. She then underwent a TMA, which then eventually necrosed and was slowly worsening, and so she was advised a below-knee amputation. On exam, her right leg pulses were normal, her left leg, only the femoral pulse was palpable. Her ABI was 0.1 on the left, and she had a good vein conduit. So we did an aortoiliac angiogram and a left leg angiogram, which showed a patent aortoiliac segment. Left common femoral, SFA, and profunda were patent, and the distal popliteal SFA and popliteal artery were occluded, with reconstitution of the anterior tibial proximally, but that occluded in the distal calf, and only the perineal reconstituted at the ankle and supplied branches to the foot. So vascular surgery performed a left SFA to perineal bypass with saphenous vein, and podiatry debrided her left foot, and then plastic surgery did a free flap and a skin graft to salvage the foot. This patient went home after an uneventful postoperative recovery. So CLI patients are very complex, and anyone who undergoes an amputation for a diabetic complication has a very high 5-year mortality rate. And this indicates a very necessity for a multidisciplinary team approach involving a high level of primary medical team awareness, dedicated foot clinics, and involvement of multiple disciplines, as we have heard before, to prevent a patient from climbing up the stairway to an amputation. So CLI is a complex disease and has high socioeconomic and public health burden. There's a low level of primary care awareness and public awareness. It's a broad clinical spectrum of disease. There's a poor classification system, and communication between providers may be hampered because of the poor classification and staging systems. Multiple providers are involved, and this may fragment care and delay care, and the diagnostic and therapeutic procedures available are very variable. Requirements for optimal diabetic foot care as well as CLI care involves ability to perform hemodynamic and anatomic vascular, podiatric, neurologic, and wound assessments, as well as ability to perform both surgical and non-surgical therapies and surveillance for high-risk foot patients. Limb salvage centers need to focus on high-risk patients with a multidisciplinary team approach. Vascular interventionalists and podiatrists are key players in this, and a coordinated inpatient and outpatient management is necessary for these complex patients. The aim of these programs should be to prevent limb amputation and to reduce the disability and improve patients' quality of life, as well as to provide state-of-the-art care for these patients with high risk and threatened limbs, and also to offer novel therapies and patient participation in clinical trials. An interdisciplinary team approach provides several patient benefits, including reduction in the time to the assessment and interventions to improve vascular care, wound healing, surgical interventions for infection, as well as correction of deformities and accommodations for the foot, and surveillance of the foot in the future. There are also some benefits to the institution in that a team approach enables the hospital to link efficiently and coordinate the team of specialists to effectively manage these complex patients. There's an incremental increase in patient referrals from community primary care physicians and podiatrists. The hospital can assume a leadership role for dissemination of information regionally and nationally, and this enhances the identity of the institution as an academic leader. This will, in turn, enable the development of infrastructure for clinical trials. So podiatrists and vascular interventionalists are key players in this multidisciplinary role, and most patients with CLI should be offered revascularization for attempted limb salvage. Both endovascular and open surgeries have a role in these patients. Technical success is necessary, but it's not sufficient, and treatment failure has significant negative consequences, leading to delayed healing, recurrent wounds, increased tissue loss, and infection. Patients suffer from recurrent pain, immobilization, repeated hospitalizations and procedures, and increased costs. The correct procedure should be picked based on patient risk, the limb stage, and vascular anatomy. Interventions for CLI are very challenging because multi-level and long segment disease is common. CTOs and extensive calcifications are also common. Advanced tissue loss requires increased perfusion requirements to support healing of foot reconstructions. Large defects may take several weeks to months to heal, and comorbid conditions, weight-bearing status, and infections may delay wound healing. Podiatry play a key role in these patients for appropriate wound care, offloading strategies, shoe modifications, reconstructive and prophylactic foot surgery, and surgical biomechanics and soft tissue reconstruction to keep the foot as functional as possible. A CLI limb salvage clinic is essential for rapid evaluation of patients by multiple specialties to facilitate timely care. Other specialty involvement is necessary on an ad hoc basis to improve care of these complex patients with multiple comorbidities. Case conference and meetings among different specialties facilitates education. And patient screening by primary care physicians is very important. And an example of this is a PAVE committee at the Veterans Affairs hospitals, where primary care physicians are involved in screening patients with high-risk foot problems and referring them to the appropriate specialties. Now, a multidisciplinary team approach requires hospital buy-in, and hence cost is important. It has been shown that a team approach, as well as limb salvage efforts, can reduce the cost of taking care of a diabetic foot by about $600 to more than $4,000 per patient. Of course, we have the BEST CLI trial, which highlights a multidisciplinary team approach, as well as the UK Basel II trial, which will also help with further data on this. Thank you for your patience.
All right, so next week we're going to invite up Tony Das, who's my good colleague from another Texan. And Tony's going to talk about from fellowship to the real world.
I think I'm the seventh inning stretch entertainment, actually, because my talk is more about things you probably learn from your mother than you will from your colleagues. But the important thing here is mostly kind of geared towards the early stage interventionalists coming out of fellowship, and just some things that are obvious but always worth repeating. These are my disclosures, not germane to this at all. So what are the 5 steps of practice development? One is the honeymoon stage. You're well aware of that. Then becomes your reputation building. And then there is a stage there where industry can actually improve and increase your overall reputation. And then there's new technology and the adoption of new technology. And then sort of the most important one is after you've been established to sort of create vision for what you're going to do in the future. So I'll go over this over the next 10 minutes and give you an idea of what I think are important phases for you coming out of fellowship. The honeymoon stage, we all know this one. You sort of come out of fellowship and you're running and gunning and joining a new practice. And this usually lasts about a year. Everybody already assumes that you have some ability because you went to a fellowship program. And the things that you're really judged on during this period of time is affability, if you're a nice person, and you're available. So those are the 2 things you should focus on during that time. Unfortunately, during fellowship, you're not really trained very well to provide good service. In fact, quite the opposite sometimes, because you're busy, you're tired, and it's not really ingrained in you that taking care of patients and taking care of referrals is an important part. But during the honeymoon phase, this is where you sort of make or break your reputation. So what is affability? Obviously, half of it is your personality, just incorporating that into being kind to people, being nice to everyone, including the assistants and the nurses, the referring doctors. It's not unusual for people to be very nice and manage up to one group, but be very negative to another group. It never works. Everything should be easy to do, and you should never consider anything to be a hassle, even when it is. Never become arrogant or be put off by anyone. And this is not easy to do, especially when you're post-call, when you're tired, when you've got that 10th case on the board, but I think it's an important part. Be super available. Go through the emergency room early. I did this for the first 10 years of my practice. Walked through the emergency room at 6:30 in the morning, got every single patient that came in with a troponin at 0.0004, and of course took care of those patients, and then the tough ones too on a vascular consultation. Insurance at this point is irrelevant. You just want to see patients and be able to be accessible by your referring physicians. After you have the honeymoon phase, you have to start developing your reputation, and it really can be ruined by some decisions, but it also is made by a couple of different decisions that you make. Mainly professional, so you're peer-to-peer, especially educating your peers, whether it's interdisciplinary education or your administrators when you're trying to bring in new technologies, being able to understand what that might bring to a hospital. We heard that in earlier discussions, that you really need to be able to show those values to them, and also to patients in the community. I mean, sometimes you'll get patients just because they'll hear you talking to another family member and say, oh, he was very nice, he explained things. Next thing you know, you're getting a patient that gets referred by word of mouth. How can you be a good cardiovascular and vascular specialist to people? One is just identify doctors that want to learn. Those that don't want to learn are never going to care about what the data says, and understand what their goals are, not yours. So for many of them, is getting things off their plate. So if somebody contacts you and says, hey, I need this patient to be seen, you just deal with it. You don't send them to another phone number or tell them to call somebody else. You bring value to their practice, and it makes a big difference. Don't assume that people know what you do. I mean, I say shame on me sometimes. I've been in practice 21 years, and I'll do a vascular procedure on somebody, and somebody will still contact me and say, "You do peripherals?" I'm like, I obviously haven't done my job if that's the case. So don't sell yourself. Let others kind of learn about your reputation, but also educate people about things. You create relationships, whether it's with your colleagues, relationships with the vascular surgeons and the interventional radiologists. I have great relationships with the folks at my hospital. And with complete projects, I think that's the other thing, is that there are a lot of things that people start, but they never complete. Peer-to-peer reputation is key, and that is organizing the data and the cases. And we see this very well at this meeting. People have done interesting cases, and they've compile them into presentations, and you should present those at dinner talks or grand rounds and understand how that differentiates your services. Many times there aren't people that are doing what you're doing, and you want to become the local expert in something. I started this 20 years ago learning laser when people really weren't doing that, but that's not what you continue with. You develop and adopt new procedures and technology as time goes on. If you're recognized as an early adopter, you will be called by plenty of people to find out if there is a role for a patient to be treated by you when new technologies are out there in the news, whether it's left atrial appendage closure, or whether it's PFO closure, or whether it's TAVR or whatever. They'll just assume that you're involved with that. So being recognized as an early adopter makes a big difference in your practice as you continue to grow it. Being a local physician leader means that people will think of you when it comes to new technologies, and being sensitive to the fact that you want to educate people. You don't want to beat them down with your knowledge. You also want to educate the community. You can do this yourself and with referring doctors and the general public. There are times when you're doing something that's interesting and you want to capitalize on patients, sometimes high-profile patients, and also be able to do these things where you'll be called by media and others to be able to comment when there's some activity that's going on nationally, and you will locally be asked to be on the news, which will happen on a regular basis if you're considered a local community leader. Also, educating your physicians, educating doctors. When I went into practice, we started this meeting called The Cutting Edge. Kenny probably remembers it many years ago. And we did that for 2 years, and then that and several other meetings got combined into a meeting that you may have heard of called Viva now. And so we started in our local community, started getting about 200-300 people, and then before you know it, we had combined into a larger meeting. This is something you don't want to do, which is open your mouth and insert your foot. And this is easy to do when you feel as if you're tired or overworked. Criticizing other doctors, it always gets back. I get referrals from other doctors that may or may not agree with what I did, and I may not agree with what they did, but I don't say anything to the patients. You don't tell them or say anything to them because it'll get back. You also want to keep a cool head because your staff and others, they don't really appreciate, and they will help you because they want to help you, but if you act, mean or rude because a chart's lost or because of other things you're post-call, that will never work. Doing new cases is really always a burden of professional honesty. Don't do a case that you're uncomfortable with, and if you're going to do a complicated case, get your colleagues involved. I will tell you there's no substitute for taking a complex case, not doing it, getting 2 or 3 other people who have great experience and being upfront about that and learning from them, and then ultimately being able to do those cases later. One more case at this stage is not the goal. You're going to do fine over the course of time. The third stage is that development with industry, and part of that is getting to know their local leaders, which you do at meetings like this. And it's very much a two-way street, whether you say that you're going to do an educational program or whether you're going to say you're going to enroll in clinical trials. Do what you say you're going to do, be professionally honest, and showing that you're organized. I keep all my cases still on a database. I have over 20,000 cases in my phone right now. If somebody calls me, a referring doctor, I can tell them what I did a long period ago, and we can also then fill out those forms that industry asks you, well, how many SFAs do you do, and how many of this do you do, and so you can give them that information. As you start to develop that relationship, new technology will come your way because you have created an infrastructure for that. Many of the people in this room are involved with research and research trials. They've created institutions that they start to really foster and partner with first industry and then, at your own facilities. Early adoption for new technology is what it allows you to do this. And if you look at the leaders in cardiovascular and vascular fields, they continue to be the same guys. They evolve, right? So it's interesting to watch someone who was an expert in rotablator in 1997 is now the same expert in TAVR. It's because early adoption leads to their ability to be flexible to join new projects, and I think it's a really great way of moving yourself forward. And the last stage, and maybe the most critical, is after these things develop, is really sitting down, spending time, and creating what you want to accomplish over a period of time, whether it's a year or 5 years, and target those local situations where referrals may be part of where you want to grow from because it's a new technology that you want to incorporate. And marketing is not a bad word, even in medicine, because you can do it with education. And I think that's the really key part of most of what I would say to you, is that you can create this over time. So those are the 5 stages. I think it takes time to get organized. Don't confuse being busy with being successful, because people waste a lot of time. Take your cases and organize them, because you may be asked to present them at something like a conference like this. Learn the process. Don't be part of the complaining organization, but be more of someone who can actually understand what it takes to get something done in a hospital or even in your practice. Take some time off to learn some things that are not really germane to us. It's not just doing a procedure, but understanding what some of the other pieces are, whether it's billing or coding, et cetera. And finish today's work today, because tomorrow there'll be more of it. Thank you very much for your attention.
Thanks very much, Dr. Dass. I wish I had heard you 20 years ago. I think I violated every rule that you mentioned. Okay, next we have Shirling Tsai. She's going to talk about, I should have treated this one percutaneously, case-based CLI.
No stuff there. Okay. Hi, good morning. So I want to thank you for giving me the opportunity to present this case in CLI. I have to thank Dr. Banerjee particularly for giving me this wonderful topic. I feel like this originated from one of our weekly conversations in the cath lab, where he tells me, you should have treated this percutaneously, and oftentimes he is right. So this is a case of a 70-year-old man who came to us with right great toe ischemic wound. He had long-standing bilateral lower extremity claudication that was not really limiting, and in fact he had no real limitations to his physical activity until about 3 weeks prior to coming to see us, when he developed this wound. Medical history significant for hypertension and hyperlipidemia. He smoked a couple of cigars a day. And in terms of medications, he was on some antihypertensives, but no statin and no aspirin. Non-invasive flow studies were significant for no toe pressure on the right side or the affected side. He got a CTA with runoff, which was essentially non-diagnostic because we couldn't see any of the tibial runoff. So we did a right lower extremity angiogram and we vein mapped him. He had good saphenous vein on the right. Here are some pictures from his right leg angiogram. He had very tortuous iliacs bilaterally, but you can see here his common femoral was open, his profunda was open, and the proximal SFA is open, but it was occluded in the proximal thigh. There's reconstitution of the popliteal artery above the knee, but this unfortunately was an isolated popliteal segment, and there was no really good distal target until we got to the posterior tibial at the level of the ankle. So this patient was a candidate for best CLI. We spent about close to an hour talking to him about best CLI, pluses and minuses of the options, and he actually did not want to be in the trial. He wanted a bypass, which was actually interesting because most people for us, when they decline participation in best CLI, want endovascular, but he wanted a bypass, so we recommended a FEM to PT bypass with in situ saphenous vein graft. And our decision for this was a couple of reasons. Oftentimes you have a better size match between the vein and the artery when you do it in situ, non-reversed. But also there's a potential for fewer or shorter incisions with the vein harvest. So vein harvest from saphenous vein, for saphenous vein bypass can be associated with up to 20 to 40% rate of wound complications. And especially when we're going to a distal target in the ankle, we can suffer a lot of complications from a very long vein harvest site. So we thought we would try to do this in situ, and here's an illustration of how this can be done. One incision up in the groin to get out the inflow and the proximal vein, and then a couple incisions at the ankle to get out the distal target and the distal vein. And usually you can make a couple of small incisions or several small incisions along the leg to get the branches of the vein to prevent a significant AV fistula. So whenever we leave the vein in situ, we have to lyse the valves. There's 2 types of valve lysis devices, the Mills and the Lemaitre valvulotomes. Both are effective, neither is perfect. Long-term results of in situ saphenous vein bypass graft is very good in the hands of people who do a lot of them, and this group in Albany did a lot, over 2,000 cases, and primary outcomes were good at 1, 5, and 10 years, and cumulative secondary patency was excellent, 91, 81, and 70% at 1, 5, and 10 years. And in terms of limb salvage, looking at just the patients who had tibial targets for their in situ vein bypass graft, 86% limb salvage at 10 years. So we took this guy to the OR. We cut down on the groin, good common femoral superficial femoral artery, and good greater saphenous vein at the groin. We cut down at the ankle. There was a good PT target, and there was a good caliber vein at the ankle. So we did our proximal anastomosis to the proximal SFA, which is pretty common when you do these in situ. And then we turned our attention to the ankle, and we couldn't pass the valvulotome. This was very annoying. And we tried for a while, we struggled, and then ended up, we had to explore more of the vein in the calf. And it turned out the vein was not really as good as we thought it would be based on the preoperative vein mapping or our own intraoperative vein mapping. And so then what happened, we ended up having to do a spliced vein bypass. And then not only that, we ended up with many residual valves left in the vein. So we had to pass the valvulotome many times through the residual valves. And then ultimately we had a skin flap with a non-reverse transposed spliced vein bypass. Ugh. So this is our completion angiogram. The inflow was good. This is the vein bypass in the thigh. And here's a picture where you can see some of the residual valves left that we had to pass a valvulotome again to deal with that. One AV fistula that we had to go and ligate. This is the bypass in the calf, distally. Here's our distal anastomosis. Is a little bit spastic here, but he had adequate runoff. This is the outflow into the foot. So it looked all right. And postoperatively, he did okay. He had a post-op toe pressure of 42, better than 0. He had a palpable PT pulse at the ankle. And as far as this skin flap, it looked viable, so we let him go to rehab. But 3 weeks later, this flap was an eschar, and a couple weeks after that, the flap was gone, and he had exposed saphenous vein bypass graft, which is a big problem. So we called plastics. They came and depleted the calf, did a rotational flap. Then he had a right great toe amputation, which went fine. But by 8 weeks, we did a surveillance duplex, and there was a significant stenosis where this bypass graft had been exposed, which is expected. So we did an angiogram, we saw the stenosis, and we actually didn't do anything about it because by that time, all his wounds had healed, and we already knew we had a suboptimal bypass that was probably not going to be very durable. So in hindsight, in 2020 hindsight, this patient probably would have done better if we had done retrograde pedal access, recanalized the SFA, and treated the PT. But I have to admit, it can go both ways, because oftentimes we will embark on aggressive endovascular limb salvage in cases like this, where we have a flush SFA occlusion and occluded stent, and we try for a long time. We did retrograde access through the PT here, and we ended up with a good technical result at the end, many, many, many hours later, with inline flow to the AT and also to the PT. You just can't see it for the sheath here. But many times during this case, I must have said I could have finished the bypass by now. So this sentiment of hindsight being 2020 is common, I think, whenever you have two good options, endovascular or open, in these cases with challenging limb salvage. Thank you.
That's called buyer's remorse. When you're into it, you say, oh my God, I wish I'd done it the other way. It happens to all of us. So next, it's a privilege to introduce Sam Mehta, who's going to talk about, I should have treated this one medically. Welcome, Sam.
One, I want to thank the organizers for having a meeting in our own city. So we love Denver, and we've had a paucity of medical meetings and everything else. So here are my disclosures. One, I was the first fellow that ever worked with Dr. Banerjee and Berlakis when they were junior faculty. So when I got this, I was so excited that I could speak at a meeting, and I've been trying to figure out for the last 6 months, what did I do wrong where I have to present CLI medically? So when I first started thinking about how to present this, I said, oh, this is a perfect example to show what I've screwed up. And I said, that's probably not the case, because I think deciding to treat CLI medically is not done post hoc. That is, I screwed up an intervention or I lost a limb because I screwed things up. So this is a patient who's 78, he has diabetes, hypertension, CAD, right BKA, a previous left fempop bypass that 6 months prior to arrival had treatment of his infrapopliteal vessels by myself due to CLI. required antegrade access due to the tortuosity of his iliacs and his fempop bypass, and now has recurrent left and lower extremity rest pain and a grade 1 calcaneal ulcer. So he came to our amputation prevention center, and for full disclosure, the last time I took care of him, he was the most difficult non-compliant patient, didn't show up, and I must have said 5 to 15 times, I'm never taking care of him again. So he's come to our amputation prevention center then 5 times, and everybody in the center, frankly, has convinced him he needs to have this done. So, sorry, go back one. So here you can see evidence of early organized or thrombus in the fempop graft that, this is difficult to see, but extended down into his TP trunk, perineal, and PT. So we had antegrade access again. We were able to actually extract the thrombus manually, I think with a penumbra device at the time. And I said, okay, I got out of Dodge. So we took him to recovery. He woke up, and approximately 2 hours afterwards, he left. So I get a call from my nurse practitioner that says, Jim, which is not his name, signed out AMA. And I said, okay, he wants to smoke. Well, for those of you who don't know, and Dr. Rosenfield alluded to earlier, we don't just, Colorado's an otherwise healthy state. And when I moved here 10 years ago, everyone said, wow, you're an interventional cardiologist, why are you moving to Colorado? There's no work to do. So our legislature did a great thing for us, and they ratified marijuana. So what I didn't know at the time is that then becomes legal everywhere. So our patient lives in an extended care facility, but in numerous extended care facilities, when people have checked themselves in, they can do anything legal. So I now have a cohort of 10 to 15 patients who sit around with each other who've had CLI and smoke weed all day long. So he signed out AMA because all he really wants to do in life is smoke weed. So then the question is, what is the data of chronic marijuana using? Well, we know marijuana smoking is 18 times more carcinogenic than cigarette smoking at the same dose. Cardiovascular mortality and rate of MIs go up. And anecdotally, I can tell you for sure that in a CLI population that is otherwise hampered with either rest pain or pain, there is a high likelihood to smoke marijuana all day long. So as I'm walking across the hospital to my office, which is across the street, I get this call and I look and I see Jim sitting in his scooter with not one but 2 joints lit up, and he looks at me laughing, not bleeding, and says, hey, thanks for doing the work, doc. So the follow-up is he didn't bleed. He didn't bleed to death afterwards. He did fine. But I thought to myself, gosh, what am I doing? I've had my center talk me into doing this. I know the patient's never shown in follow-up, et cetera, but I've been talked into treating this guy endovascularly. And as endovascular medicine has gotten safer, we all feel like our techniques are better. I think we've disengaged the patient to some degree of what do they want, life expectancy, what are their goals of treatment, et cetera, because we know we can do most of these cases relatively safely and with an increased amount of efficacy. So again, signed out AMA. And then when I talked to him in the street, he said, all these guys talk me into doing this procedure. I don't care if I have a leg or not. I literally just want to sit around all day and get high. So to conclude, I think CLI strongly requires patient compliance, their own concern, and otherwise is both professionally and patient unsuccessful long-term. And our decision to proceed with revascularization should be done prior. So we should not look back and say, I perfed a distal vessel and got a below-the-knee amputation from that, so I should have treated him medically. It should be an upfront decision before. For those of you who are looking for a complication, we did present this on the CVI Innovations live webcast a couple months ago, where Ian Kowich yesterday presented a very nice talk on radial interventions. This is an example of not appreciating the difference in outer diameters of a glide slender sheath and a destination sheath that caused excessive spasm, and that is the radial artery that has been harvested due to my over-aggressiveness endovascularly. So thanks for coming to Colorado. Thank you.
Okay, folks, we got one talk left, and then please have. Oh, excellent.
Can I say one thing about Sam? Sam is surprising me again today. I was thinking he's going to talk about like something like B-cell or ANCA-mediated inflammatory vasculitis causing distal foot ulcers that will be treated with some TNF-alpha antagonists in addition. But that is a refreshing way of presenting the talk. Fantastic.
Subhash, that talk is for people who practice in academic medical centers. So in private practice, that's too much thought for my head.
All right, folks, we've got about 15 minutes or so for questions, so please jot down your questions, and I think we have a microphone that we can pass around.
I have a question about CLI. It is all over the country now. So many programs, many teaching, but if you the CLI, we have programs all over the country. When we started it, there was hardly anything. Over the last 7 years, we are reviewing the data from the US, zero change in amputation rate, just minor increase, no, actually significant increase in minor amputation rate. The number of interventions are increasing. How can we explain all this?
Kenny, you want to take that question?
Actually, I don't know where those data are from, but I actually thought the amputation rate was decreasing a little bit. But, you know, notwithstanding that, I think we have a lot of education to do. And the reality is that most amputations don't happen in our centers. And I think that while there is an increasing number of, you know, focus and interest on CLI, I still think there's a lot of CLI that happen, a lot of amputation that happens that I've heard about that is sort of, places where people are not really focused on this disease entity. And, you know, in order to make a real impact, it needs to be penetrated throughout. We need to do a better job of sort of saying no patient should get, there's a study that showed the number of patients that get amputations without actually looking at vasculature, and it's actually remarkably high still. And I think that's probably the reason for the problem. People don't even consider a vascular issue, or they just go right to amputation in many settings. I don't know. I also think we have ways to go with risk factor modification and medical therapy and so on. Not marijuana medical therapy, but you know, true medical therapy.
Actually, I just want to clarify. I think Dr. Shishabur and our next moderator, Dr. Phil Goodney, both have pretty remarkable papers showing endovascular rates increasing, surgical bypass the same or decreasing, and amputation rates actually decreasing. So I don't know if, Mehdi, you want to comment? You got that beautiful paper last year, I think.
I don't want to take too much time, but actually not only amputation is decreasing, mortality in patients with CLI is decreasing. The other fact that's very important, specific to CLI, the endovascular procedures actually plateaued. So they did rise significantly in the mid-90s and early 2000 because of, I think, all the innovation and all the things we were learning. But I think now they have plateaued. There is a lot of venous procedures that are being done, but CLI has kind of settled down.
Got it. Dr. Dunn, let me ask you a question. You talked about a multidisciplinary team and how the challenges. Give us some ideas about how you can align incentives, because that may be one of the critical issues on how you get a team working together.
Yeah, like you mentioned in your talk, it is very difficult. I think it depends on the health system you're in, how your employment is structured. You know, I'm an employed physician. We have employed physicians in our practice, and our health system kind of oversees all of our vascular specialists. If you have multi-specialty groups that contract with a hospital, that makes it more difficult, especially if you have different endovascular specialists that are doing similar things but have, you know, they're both paid differently from the other. So one thing that we're doing, we're literally trying to redo the contracts for everybody that does endovascular work. I mean, that's one thing that we have found that, you know, if you're benefiting from doing a procedure and the other guy benefits from taking that patient from you and doing the procedure, then we need to realign the way the contracts are structured to benefit collaboration. We've tried to find ways to incentivize outreach. So, you know, maybe setting a standard for going out and giving talks in the community and sharing those among all the endovascular specialists. So it actually, in my institution, it's a work in progress, but that's kind of the approach we've started going toward, is actually restructuring the way people are, the way reimbursement works for the specialists. Because as Vic said, that what this boils down to eventually is that if, people want to have control of the patients and take care of the patients their way, and some of that is fiscal, a lot of it's fiscal, and that's what it boils down to.
Somebody up there.
I have a follow-up with that, and that is, we looked at those graphs, and we saw how IR has dropped in terms of endovascular therapy. How do they get back into endovascular therapy in these collaborative models? And, we talk about being collaborative, and, obviously, we're in a place, obviously, we do a lot of endovascular. We have surgeons that do endovascular and open, and, we have cardiologists, interventional cardiologists also involved. How are you able to share that amount of experience? Let's forget about the economic, the financial part of it. And so that as you have interventional radiologists that are training, they also can be involved in endovascular care. Because what's happening is, we're losing that at that training, at those training centers. They're not part of those vascular centers in terms of those collaborative models.
Just to add one other thing, I think if you're in a smaller center or place where you can't align incentives or devices, I think engaging the other subspecialties gets you a long way of establishing your reputation. So you may lose some cases early by talking to a vascular surgeon and having them operate. When you're early in the world of lysis and you haven't done a lot and you're establishing your reputation, talking to IR, who lyses a lot more things than you do as an interventional cardiologist, makes so much sense, because then 1, 2, 3 years down the line, you've established the reputation of taking care of the patient rather than trying to do too many procedures.
I mean, that's the sacrifice that I actually mentioned in my talk, because it requires sacrifice and being willing to give up things for the, for the having a long range picture. I don't know the answer to your question, Tino. It's a really challenging one, because I think we need to think about workforce issues too, and we don't actually. This is something that hasn't been mentioned today, is how many people does it take to actually take care of all these patients with CLI, and what's the mix? Every place is a little different. But if you have too many people and they're tripping over themselves looking for cases, as actually happens in my case, in my place a little bit, then it becomes very, then it's harder to align those incentives. Anyway, just a comment.
Dr. Dunn, do you use a vascular medicine specialist to help guide care of patients, and if not, do you see that as a model in the future?
It's an excellent question. So we do not have a vascular medicine specialist at my institution. We have one endovascular specialist who's a cardiologist, but not an interventional cardiologist. He did vascular interventional training, and he has some vascular medicine training. So he will see a lot of these patients. The model that I'm trying to set up at our institution is a vascular clinic that my vision for it is it is run at some point in the future by a vascular medicine specialist. So somebody that can coordinate care and understand vascular medicine to the point that you can really decide what is the best treatment option for this patient and who do you involve in this case to understand the best treatment options. Because as we all know, in a lot of these cases, medical management is the best option. It's not an endovascular or surgical approach. And so having somebody that understands that and can really determine kind of where to place the patient in our health system and who to place them with, I think would be extremely beneficial. We don't have that at this time, but that would be my vision for our vascular clinic.
I want to follow up with that, because we hired in our group a vascular medicine physician about 5 years ago, and it really changed the way we practiced. It really was very helpful in terms of, like you said, evaluating the patients, helping you pre and post procedure, during the procedure, making these decisions. Extremely helpful, and they basically increase the care that you're providing to your patients all across the board, right? Because you start learning certain things. You're not going to send everything to that vascular medicine physician at the beginning. You do, and then you start figuring out, okay, I can handle this. But then as you start getting certain things, they can really be a gatekeeper, and they can also really help with the patients. And I think that's really, it brought up the bar. When we look at all our metrics that we follow, I would say all those metrics are things that our vascular medicine physician help institute and really help us in terms of hopefully quality and all the things we talked about are the way we're going to be judged. Sure.
Dr. Raniel, I'm sorry, go ahead. Dr.
I was just going to say, from a health system perspective, it also increases efficiency. You can have a vascular medicine specialist or two seeing patients in the office while the endovascular specialists are in the lab or the surgeons are in the OR in the lab. So, from a health system perspective, it could certainly increase efficiency.
Dr. Pena, a couple of technical questions for the group. You mentioned the critical importance of the profunda femoris. What happens if that artery occludes? Illuminate the problems for the crowd.
I mean, I've been told by all my surgeons that basically it is probably the most important artery to define your leg. You know, if you lose a profunda, I think you're really on thin ice in terms of keeping that leg in place. You can do a lot of things to the SFA. If your profunda is intact, you pretty much should be able to get collaterals. You should be able, there are options. Great. So that's why I think the profunda is so important. I mean, a lot of times people can live off their SFA, and you'll see patients like that. And a lot of times when you look at non-invasive examination, you say, wow, this is really, this looks worse than it should be. Look at the profunda. There's probably something going on there.
I think the issue is that what happens if the profunda is down or lousy, and then you have the SFA as the conduit to the leg. And I grew up with that same mantra that the profunda is the most important artery to the leg, period. End of discussion. And if you just do a profunda, in fact, even for CLI, we used to do, and Vic, you probably know this, and Shirling, you might, as surgeons, you guys know this, but you can actually just do a profundoplasty and common femoral patch angioplasty and sometimes actually get healing through incredible collaterals. But sometimes the profunda is down. And I think the patients that we're seeing are so far advanced now that, you see one patient. But as a general rule, I agree with you.
Great. Dr. Tsai, Dr. Ramanan, Dr. Tsai, you showed a great case. And my question for you, could a bailout have been bypassed to the isolated popliteal? And I wonder what your thoughts are. Dr. Ramanan, why don't you weigh in?
Generally, in CLI, we don't do any bypasses to isolated arteries. We try to get inline flow to essentially a pulsatile flow to the foot. And so I think I agree with what Dr. Tsai did in that case, in the sense that she went to the artery that was patent to the foot, which was the PT at the ankle. Whether, looking back, bypassing to the pop was the best option, I still don't think that would have been the best option, since there was really no inline flow to the foot.
Can I challenge you on that? I mean, we talked about this, Vic. I mean, I actually think that an isolated popliteal bypass with amazing collateral flow around the knee can be a very effective treatment even for CLI. It depends on the extent of damage. This patient had a toe ulcer or something like that. And I'll bet you $100 the patient would have gotten better with just an isolated bypass to the popliteal. But the sort of, again, the gold standard supposedly is distal bypass, but I'm not so sure that's true. And I've seen many, many patients get better from that. So I think sometimes our long-held beliefs aren't always, we cling to them, but I'm not sure they're always true. Of course, but I don't know.
Yeah, so I think, the textbook answer is that you need inline flow to the foot to heal a wound, not necessarily for rest pain, but to heal a wound. So, but then I think I agree, on some level, I do agree. If he had great geniculates and collaterals off the popliteal, then maybe that would be enough to support a bypass with a good conduit. Like, I wouldn't do it with PTFE, but if he had good vein, I would consider that if there were great collaterals. In this case, I didn't think he had good enough collaterals off of the popliteal, but also you kind of look at the patient, because if he was also kind of a high-risk, not-so-great patient, then maybe I would have tried that. But he was a very functional guy, had no other major medical problems, so we thought that, and I was completely misled by the vein mapping that showed good single-segment saphenous vein down to the foot, because that, in those cases, I think it is worthwhile to try to do the in situ bypass. And when that works, it works very well. It always turns out more painful than we think it's going to be, because invariably there are going to be branches that you have to go after to get the AV fistulas and whatnot. But based on our preoperative workup, I thought this was probably the case to do it.
So and just to be clear, I wasn't suggesting that it wasn't the right thing to do. I'm just suggesting we hold these beliefs, we hold these truths to be self-evident. They may not always be. So, so we're dogmatic about them, and it may not be the case.
I agree. And what?
No, he
healed.
He didn't. He lost a toe, which is what we thought. We knew that toe would go, but he has not lost his leg. So he had, the exposed vein bypass is a problem, which is why the day we saw the exposed vein bypass, we got a flap. We got a rotational flap, and then that. I think what happens is with, whenever it's exposed, it's going to become stenotic. So that was inevitable, but the nice thing about the vein bypass is oftentimes if they go down, you kind of return to your chronic state of ischemia, as opposed to the PTFE bypass, they go down and we end up with an amputation. So, and because the outflow thrombosis, so that's our real bias towards vein bypass.
Yes, sir.
I'd like to push the envelope. What about, we talk about multidisciplinary, engaging each other. We have young, fellows both on the vascular surgical side, but also IR and interventional cardiology. Why not take a case like that and collaborate together with FM above knee bypass the vein, and then doing endovascular for growth?
Right.
I mean, in my mind, why not get interventionalists more in the ORs and get the vascular surgeons together in the cath lab?
Yes.
Answer, I don't see that. They are so tired of me.
No, we're not tired of it. Dr. Banerjee is great. He came, we had a case, he came and held the retractor for us one day. All, for like 4, I think
Maddie,
it was
I have
like 4
a case for
hours.
you on Monday. I need a retractor holder.
I think it was like 4 hours of common femoral endarterectomy profundoplasty, and he held the retractor until like midnight, I think. It was.
The reason I'm saying that I want to say one thing, sorry to interrupt, but Kenny made a very important point, that these kind of discussions we are having have to happen in a formalized setting. So what Bala and Shirling have done at our institution, actually made a regimented Thursday morning conference where we actually just sit down and discuss that case. We actually show up there with coffee and actually do it. It's exactly what you guys are doing, and push back on each other, review angiogram images. And I think that is the formalized part is very important. And then Kenny would love this music. We decide that maybe this patient should be randomized because we can't really come up there.
Yeah, actually, well, so I'll say I appreciate you guys actually tried to randomize that patient. Thank you, because it's a perfect patient. But in the absence of that, another alternative is to do a fem above knee bypass and then wait and see how the patient, or the fem pop above knee endovascular and see how the patient does. To my point before, maybe the patient won't heal, and then you can actually do another. Now it's another procedure. I know that it's another OR trip, but it may actually be better to do it staged like that.
But oftentimes what we do
thinking out of the box.
if they have profunda disease, actually common femoral profunda disease and a wound on the toe, we'll stage that. So we will open up the common femoral and profunda and then plan for a possible second procedure if the toe wound doesn't heal.
In Cleveland, we have nobody with veins from the groin to the foot, so we always have to do something. Dr. Das, you mentioned some very critical points for starting out in practice. What if you screw up the honeymoon? How do you resurrect your practice?
Great question. Well, I mean, the only way to screw up the honeymoon is to not collaborate and not understand your limitations, and also realize that taking on more than you can actually chew is a really bad idea. So the way to do that wrong is to not do these kind of collaborations. I think that, based on the conversations that I'm hearing next to me, is that where we really don't have good conversations is when the cases are difficult, right? So when they're simple, everybody says, I can do this or I can do this. But in a case like the one that you presented or that you did, it's like the case that nobody wants to do are the ones we ought to be talking about. And I think that that's when, we oftentimes will defer to a surgical option, and then that surgical option then fails. Then we're back to an endo option when we could have probably thought of an interim hybrid approach like the one that we talked about. But, generally speaking, I think the way to screw things up is to be too arrogant when you start, to recognize that what you did in training is something that you need to let people understand and recognize and collaborate to try to grow that, because you can't come into an environment and change it overnight without having at least some brownie points, which include collaboration. So I think that the way that people ruin their reputation is that they show up as if they're the local expert when really they're just the fellow who was with someone who was an excellent educator, like maybe Subhash or Mehdi, and then you come up to your location and you try to emulate that without really allowing people to sort of recognize that you're really in this for the long haul and trying to do a good job, and they look at you as competitive as opposed to collaborative, and it's dead. And it's dead from the beginning. And, I've had docs say to me after 15, 20 years, and they've been, not great at collaboration, said, why don't people send me cases? Well, because you're kind of an a-hole. I mean, you've been that way for a long time. Let's be real about it. So.
No, I was just going to make, it's a great assessment. It's hard to retrieve. It's, it also takes it's a two-way street. And so, Tony, I mean, where you're working depends upon, who you're interfacing with. And there's certain points at which you may not be able to, so you got to stand your ground as well for some of these things. I just want to make a comment about, some of the cases that were presented, which are amazing. The failures and issues that were encountered may have been based on pharmacologic issues. And I don't think we quite understand the pharmacology associated with some of these patients. The small vessel, Tino, the patient that you had with small vessel disease and using lytics and then thrombosing and everything. I think we're learning a lot more about this, and I think we need to actually integrate that. It's not a natural thing for an interventionalist or a surgeon to be thinking about the pharmacology aspects, but it really may make a difference. I think the data with, for example, the Compass trial, pretty remarkable that you're saving limbs and saving lives by a really low dose of an anticoagulant that may change the way we practice. In fact, I sort of wonder in that case, Tino, and in some of the other cases, whether those cases might have been salvaged had we, with that kind of approach, anticoagulation. We need to, that's some area where multidisciplinary collaboration really could benefit everybody if we sort of say, what about low-dose anticoagulants?
What do you think, Dr. Mehta? Should we be giving rivaroxaban to everybody?
I mean, honestly, I think the early data looks great. I think we've got to wait and see what the follow-up study shows in 2019 when we get full data. But it is enticing. We were approached originally to be in the trial, and I said, honestly, till I have data, which is kind of backwards way to approach a trial, I don't really want to put my patients on anticoagulation. But it is very promising.
Yeah, great. Any other questions from the audience? All right, I want to thank all the speakers for a great session.